So let's go to the next question. Anterolateral cordotomy is done and it has interrupted the pain of the right leg. So you need to remember, dorsal columns will not decussate at the spinal cord level, they decussate at the level of the brain stem, whereas in the case of the anterolateral tracts which carry pain and temperature, they decussate at the level of the spinal cord itself is what need to be remembered. So it will interrupt the left lateral spinothalamic tract. So please remember, doctor, they are typically the afferent A fibers and C fibers. C are unmyelinated and A delta are basically myelinated. Accordingly, you have two types of pain. A fast pain, a slow pain. Two types of pain is there. C is basically a slow pain. And that will be carried to the cell body, and from there it will be entering into the anterolateral spinal thalamic tract. It will be immediately decussating. And it will be traveling here to finally reach what is called as the thalamocortical fasciculus, because thalamus is basically called the bedroom of the body, of the brain. What is the bridge of the brain, doctor? Pons. Pons in Latin means to say bridge. Cerebellum means small brain. Basically pons will bridge what to what? The cerebellum to the big brain, cerebral cortex. It will also bridge the medulla with the midbrain. Hence pons is called the bridge. So after reaching here, finally it will be reaching the primary sensory cortex is what I want to underscore to all of. So it is contralateral. Let's go to the next question. Fetal hemoglobin has got a strong affinity for oxygen and a low affinity for 2,3-DPG. So that you need to be very clear about, doctor, based on this question. So this is the normal oxygen dissociation curve. What does it show you? At what partial pressure of oxygen 50% of the hemoglobin got saturated is given by this typical graph called oxygen dissociation curve. Now the question is, even at a lesser partial pressure of the oxygen only, if the 50% is achieved, that means to say it is a hemoglobin with more affinity for oxygen, it is not ready to give that oxygen, is what need to be remembered. Now let us look at the maternal hemoglobin, human fetal hemoglobin. If you take these two, the human fetal hemoglobin is having 50% oxygen saturation even at a lower PO2. Hence it receives the oxygen, and human maternal hemoglobin will deliver the oxygen, is what need to be basically remembered. So this gives you another classical example how the oxygen dissociation curve will be shifting. If the pH is lesser, then the hemoglobin should be ready to deliver the oxygen. That means to say at a higher PO2 it should achieve 50% oxygen saturation, not at lower PO2. Okay? So it will be shifting in the downward direction is what need to be remembered. So finally the conclusion is oxygen dissociation curve will become shifted towards the left in the case of the human fetal hemoglobin. Left of you, not that of the examiner, be very sure. There also used to be right-left confusion, Justman syndrome, all these things should not exist. Okay? Let's go to the next question. Beta waves of the EEG, another stock question, doctor, you should not do a mistake in this question. Remember, we are awake, we have a NREM sleep, REM sleep is the broad division, and in the awake state we are alert or we are relaxed with the eyes closed. When the eyes are closed and we are relaxed, it is alpha waves. When we are alert, it is the beta waves is what need to basically remember. So one of my friends used to say, beta bahut alert hai. So that is the reason beta is basically alert is what need to be basically remembered. And in the NREM sleep, you will have stage 1, 2, 3 and 4. And out of this, stage 1 will be having theta waves, and stage 4 is basically mostly delta waves is what need to be remembered. One more favorite question of the exam is, where do you see the K complexes and spindles? It is in the stage 2 of the NREM sleep is what need to be remembered. Finally comes the REM sleep. So beta bahut alert is what need to be fundamentally remembered. Let's go to the next question. 24-year-old primary gravide, 57 kgs, visits an antenatal clinic during second trimester. What do you want to say? Additional intake of 300 kilocalories is the rule. After cervical spinal cord injury, which is a very important sign that you will be seeing, doctor, which is not the one which you will not be seeing, is a question that had been asked. Nowadays more clinical questions are appearing. Of course, in our context, where do you find cervical cord injury? You find lot of laborers carrying heavy loads, they can have a cervical cord injury, you should be very careful about. If there is an abdominal breathing where diaphragm is not working, means probably the lower cervical injury is there. And if there is any burning pain of the hands, it suggests C6, C7 injury. And generally you expect the sphincter tone to become lost, not to become increased in the case of the spinal cord injury is what is the important thing. So what are all the clues to say that there is a spinal cord injury if you have a comatose patient? Comatose patient cannot give you a very good history, and you need to basically diagnose based only on your knee hammer, and on your clinical examination you must clinch the diagnosis, doctor. Flaccid areflexia will be there, diaphragmatic breathing, loss of the grimace, loss of the withdrawal response, loss of the sphincter tone. Priapism is another important thing that you come across in the comatose or intoxicated patient who has got a cervical cord injury. Hence, the answer would be increased rectal sphincter tone would be wrong. There will be decreased rectal tone is what need to be remembered. Let's go to the next question. Ketamine had been a very favorite question once more for the examiner. Typically, it has effect on the intracranial pressure. It does not. It has less effect is wrong. What is the mechanism of ketamine's action, doctor? Ketamine blocks the thalamic cortex transmission which will be occurring, hence it leads to development of the dissociative anesthesia. But the problem with the ketamine is it will cause an increased amount of the cerebral blood flow. That's the reason it can cause a rise of the intracranial tension is what I want to underscore to all of you. Now the question is hallucinations and confusions. Do they occur with the ketamine? Very much they occur, and typically they are more common. Those who are already given atropine also as a part of a pre-anesthetic medication. In addition, ketamine is also given as an induction agent that lead to development of more amount of hallucinations is what need to be remembered. If they develop at the time of the ketamine anesthesia, midazolam is considered to be the treatment of choice. And ketamine can cause increased muscle tone, increased secretions, especially salivary and tracheobronchial secretions. It leads to dissociative anesthesia just like the phencyclidine. It also leads to profound analgesia. It can make the patient to remain in a awake state. That is very important. Dissociative anesthesia is one important property is what I want to underscore to all of you. Let's go to the next question. Double lumen tube is used for the lung surgery, and you want to confirm its position. What is the best way of confirming it? Two questions have surfaced in the AIIMS entrance this time. So let us be very clear about it. Bronchoscopy, how it goes into. Typically, endobronchial intubation with a double lumen tube will enable a single lung ventilation in order to do a pulmonary surgery. Suppose you are operating on one lung, the other lung only need to work. Then in that case, you will be doing an endobronchial intubation with a double lumen tube is the one which helps you. But after you place a double lumen tube in a single lung ventilation surgery, at that time, how do you check it? You simply insert a bronchoscope into the tracheal lumen and check whether the carina is visible or not. Carina typically appears like a sharp line. So by using the bronchoscope, you can know whether this particular what you call double lumen tube is well placed or not is what need to be basically remembered. So there is an example of how the bronchoscope can be used to identify and check the position of the double lumen tube placement in a patient in whom single lung ventilation had been done is what I want to underscore to all of you. Now let me ask you another important question. Another question in AIIMS entrance recently. One lung ventilation, why will the hypoxia will occur? One very good question. Now you need to know basically that you will be placing the double lumen tubes with one lumen opening just above the level of the carina and the other is inserted into the main bronchus. Now the question is, what happens in the regular physiology of a human lung in relation to ventilation and perfusion is my question to all of you. Are our upper part of the lungs are more ventilated than the lower parts? Are our upper parts of the lung are more perfused than the lower parts? So please remember, doctor, when the patient is awake, because of the gravity, the dependent part of the lung will be having a greater blood supply than the non-dependent part. That is, the lower part of the lung will be having greater blood supply. One more important thing is, the dependent part also will be preferentially ventilated than the non-dependent part. But don't ask me a question. Sir, please ask me a question. That sir, Mycobacterium tuberculosis survive better in the upper lung because of the better oxygen partial pressure. No. And I thought that it is all because it is more ventilated. Keep the tuberculosis logic there only. Try to apply this different logic. Sometimes clubbing the logics is one of the reasons that we fail in entrances, doctor. You need to be doubly careful about. So the dependent part, the lower part is preferentially ventilated is what need to be basically remembered. What is the reason? The reason is generally it is slightly more compressed than the non-dependent part. You take the upper part and lower part is generally more compressed. So that is the reason it is the one which is preferentially ventilated compared to that of the upper part of the lung, hence ventilation is more, perfusion is more at the base of the heart. There is a dependent part than the non-dependent part is what need to be basically remembered. Another important reason why it is preferentially ventilated is, generally the lower part of the lung will be in a collapsed state. An atelectatic segment of the lung will have a better compliance. So it is the one which is easily ventilatable than the upper part. Now I will give you one important logic how we blow a balloon. When you blow a balloon, typically the pressure required to start the blowing up of the balloon, the atelectatic bits will become easier as you keep blowing. But once it reaches a particular value and it is no more in a collapsed state, at that time for you to blow you require larger pressure to blow it. So if you take the upper part of the lung and lower part of the lower part of the lung is like that a collapsed balloon which you are starting to blow. The upper part of the lung is like a blown out balloon already, because generally it is not in a collapsed state. Hence preferentially at any given point of time the lower alveoli which are generally in a collapsed state are more ventilated every time the air is entering, and the upper part of the lung is not less ventilated. Generally it will be in an opened up state, not in a collapsed state, is what I want to underscore to all of you. So there is a reason, doctor, if you take the ventilation perfusion in a given individual, the lung that is perfused but not ventilated will create a particular amount of shunt, which is generally about 1 to 2% is what I want to underscore to all of you. Now if you take a patient who had been anesthetized with single lung ventilation, all these physiological collapsed and non-collapsed logics that we have used now, they become more exaggerated, because that particular lung which is not ventilated is in a more collapsed state, and it is the one immediately as you blow the air is the one which to become more ventilated than the lung which is not in a collapsed state. So because of that there is a more amount of desaturation of oxygen which will be occurring. Situation where you are doing a one lung ventilation, the most common cause of the hypoxia undoubtedly is the collapse of one of the lungs which you have created by promoting a one lung ventilation by using a double lumen catheter which collapsed one of the lung and made only one lung to become ventilated is what need to be remembered. Of course, soiling of the lung secretions and sometimes the tube blocking that both the lungs, there are all the other reasons, but most common reason is the exaggeration of this physiological collapse of one lung in the one lung ventilation is responsible for the desaturation is what need to be fundamentally remembered. So let's go to the next question. It is little overhead transmission question. Don't worry. This is one of those rarities. If you are too good, gold medal, super platinum medal candidate, that's a different thing. But simple questions should not be done wrong. Like Glasgow Coma scale, it can be 0 also, you should not answer. The most minimum score possible in Glasgow Coma scale is 3. That's good, that's good. So 3 components are there. EVM, eye opening, verbal response, best motor response are the 3 options. Now the patient is opening eyes to painful stimuli, he is confused and localizing the pain. Then what is the Glasgow Coma scale? Let us start, doctor. Opening to painful stimuli, where is it falling into? Glasgow Coma scale 2, so it is E2. And he is in a confused state. So how is the verbal response? Confused conversation is 4. And he is able to localize the pain. So localizing pain is score 5. If we can obey the command, it is called 6. So it is E2, V4, M5, which is equal to 11 is the score is what need to be fundamentally remembered. So nowadays examiners wants to know whether you have done your clinical posting also very good, housemanship well and coming to the post graduation or not. Otherwise postgraduates without a good housemanship will first start the Foley catheterization after they enter the post graduation. So you need to be very careful about. Okay. So let's go to the next question, doctor. For the cardiac arrest, they become worsened if you give which of these fluids? Okay, I like to ask a question. Of all these fluids, which can be considered as the fluid of choice for the resuscitation of a patient with the cardiac arrest, doctor? Undoubtedly, it is the lactated ringer solution, which is the resuscitation fluid of choice. And it has got a lot of advantage over that of the 5% dextrose. Why? Because this dextrose is poorly metabolized in the presence of a high catecholamine levels which will be there in a patient who is in shock. When it is not metabolized, what will happen? It lead to hyperglycemia, the dextrose part, that lead to osmotic diuresis, that lead to further dehydration, that lead to further worsening. Hence 5% dextrose should not be used. Ringer lactate is the choice. How about colloid solutions? They are very expensive. And Compared to that of the ringer lactate, they can't equilibrate, but anyway you can give colloids. If is a hypovolemic shock also associated whole blood transfusion, and you need to give ringer lactate but not 5% dextrose is what need to be remembered. Let's go to the next question. 2-3 peculiar anesthesia questions are there, you need to be doubly sure. 5-year-old child with cyanotic heart disease, plan for induction, and what is the induction agent of choice? You need to remember ketamine is the agent of choice, but you may ask me a question, one of the favorite thing, can you give ketamine to a patient who is having ischemic heart disease? You should not give. Why? Because ketamine will increase the total peripheral resistance and that can worsen the ischemic heart disease, but the ketamine is relatively contraindicated in conditions like hypoplastic left heart, or if there is any critical aortic stenosis, or if there is any anomalous left coronary artery, or if there is any ischemic heart disease. But ketamine is considered to be the choice agent in the case of the tetralogy of Fallot is what we need to fundamentally remember. And ketamine anesthesia should not be used 3 situations. If there is an elevated blood pressure or preeclampsia, or if there is any heart disease in the patient, you should not use it. But one place where it can be used is in the cyanotic heart disease like tetralogy of Fallot. It is considered to be the agent of choice is what I want to underscore to all of you. So let's go to the next question. 30-year-old woman with coarctation of aorta is admitted for cesarean. What do you want to do? Do you want to give spinal or general or epidural? So nowadays the pediatric cardiac surgery protocols and nowadays all is painless surgery, right? So epidural anesthesia, early extubation following surgery, and modulators of the pulmonary blood flow, they are all the modern what you call practices of the anesthesia. Now epidural anesthesia, it provides an excellent pain relief without sedating effect, and another important benefit is the patient can return to an unassisted breathing mode compared to general anesthesia. In the case of the epidural anesthesia, much faster. So that is the reason epidural anesthesia is the one which is preferred. Let's go to the next question. Cardiovascular monitoring technique, out of all this, which is not the one? Capnography, pulse oximetry, they are not cardiovascular monitoring techniques, doctor, whereas all the remaining are the techniques. So now what is the primary goal of any anesthesiologist is to basically prevent the hypoxia. So capnography basically will be identifying those situations that lead to hypoxia. So this will be a typical inspired carbon dioxide and tidal carbon dioxide. This will be continuously monitored and a curve becomes generated like this with inspiration expiration, and that will be appearing in the monitor. So basically capnography is only to know about the degree of hypoxia. It has nothing to do with the cardiovascular monitoring is what need to be remembered. Another parallel question that is asked often is what is the difference between that of arterial blood gas analysis and pulse oximetry? Pulse oximetry calculates oxygen saturation, whereas the ABG calculates partial pressure of the oxygen. So that difference need to be appreciated. A patient with PDA, another stock question, which is the inhalational agent of choice, enflurane. Let's go to the next question. 45-year-old woman presenting with a history of diplopia, dysphagia worsening over the end of the day is classically a case of myasthenia gravis, which is called the decremental conduction. By evening it will happen. Lambert-Eaton is the incremental conduction, which is seen in the case of the out-cell carcinoma as a paraneoplastic syndrome. Now, perioperatively you want to know how is the myocardial perfusion. Nowadays one of the favorite topic in the intensive care unit management of the patients in the surgical units is perioperative ischemia monitoring is one of the important protocols. Now, how do you want to identify in the perioperative period how is the myocardial status? So please remember, doctor, after the patient had been operated and shifted into the intensive care unit, typically an endoscope is passed and transesophageal echocardiography is done. So it is considered to be the investigation of choice, which can look into this endoscopic probe, can look into the surface of the heart and can know are there any regional wall motion abnormalities and can detect the presence of any regional ischemia. So that is the reason, doctor, in the modern detection of the myocardial ischemia in the perioperative period protocols, TEE, transesophageal echocardiography, is considered to be one of the important modalities is what I want to underscore to all of you. Now, let's go to the next question asked in the last entrance. Swan-Ganz catheter is basically placed to calculate the pulmonary capillary wedge pressure, which speaks about pressure in which chamber of the heart, doctor? Left atrium or right atrium? Left atrium. Left atrium should not be forgotten. You place a central venous pressure catheter and basically will check in the case of right atrium. Very good, very good. Now, as the catheter is passing, you look into the monitor how are the pressure changes. Now, you have a right atrium, right ventricle, pulmonary artery, and finally pulmonary capillary wedge pressure is calculated. Now, if you look at all these pressure tracings, where are you finding an anacrotic, a dicrotic notch, doctor? It is found in the pulmonary artery. The moment the wave starts showing this dicrotic notch, immediately your CT surgery sister will be saying, nurse will be saying, doctor, I think you entered into the pulmonary artery is what she will be telling, because they are experts from times immemorial. When the monitor was brought first time to the hospital, they had been seeing that surgery. You are the first time doing that procedure. So you will find the presence of this dicrotic notch from the closure of the pulmonary valve. That's how you will be able to trace it. Now let us look at the other options. Diastolic pressure is lower than PA than in RV. Is it like that? PA and RV are having similar pressure, so that is not a true statement. Diastolic pressure is higher in PA than RV. It is not like that, it is equal. And RV pressure tracing for the plateau and the sharp drop in the early diastole need to be checked for. RV pressure tracing will not have all those plateau and the sharp drop, it is not occurring. So that is the reason the answer is PA will be having typically a notch, is anacrotic notch is what need to be remembered. Quickly tell me, doctor, what is the mean right atrial pressure which you will be using and monitoring for the fluid administration after placing the external jugular or internal jugular catheter? It is 0 to 7. Right ventricular pressures are 15 to 25. Pulmonary artery pressure is between 15 to 25. Pulmonary artery wedge pressure, which is in the left atrium, is 6 to 12 is what need to be remembered, doctor. Because if it is more than 12, that lead to the jamming of the blood in the lung, leading to pulmonary edema is what need to be remembered. Similarly, a patient has come with sudden onset of the shortness of the breath. Earlier he was having DVT. You are suspecting possibility of pulmonary embolism with the development of an acute cor pulmonale with the pulmonary hypertension. At that point of time, check for this pulmonary arterial pressure. If it is between 25 to 40, it is called mild pulmonary hypertension. 40 to 60 is called moderate. If it is greater than 60 millimeters of mercury, it is called as the severe kind of pulmonary hypertension is what need to be basically remembered. So RVSP, right ventricular systolic pressure, will give you an indication about the pressures that are falling on the right ventricle from the pulmonary artery. By calculating the RVSP indirectly, echocardiographically, you can know what is the pressure in the pulmonary artery. If it is between 25 to 40, it means moderate. More than 40 is considered to be severe, is the golden. More than 60 is considered to be severe, is what need to be basically remembered. Okay, let's go to the next question. Classical clinical warts question. This is, doctor, angina, syncope, CHF. Classically, which valvular heart disease do you expect? Aortic stenosis should be your undoubted answer, doctor. Now let us look at the aortic stenosis. Angina. There are three gurus that you should not forget in relation to the aortic stenosis. Why there is angina? Is there at rest, doctor? No. Angina on exertion is a classical feature in aortic stenosis. Why, doctor? Whenever you do exertion, you expect cardiac output to increase. But in a patient with a stiff aortic valve with aortic stenosis, there is a fixed cardiac output. It can't increase according to the demands. Hence, there will be a typical angina which is much more on the exertion than at the resting state. Is what need to be remembered as angina on exertion. Suppose if a patient with aortic stenosis is also having angina at rest itself, what you should suspect? Probably this fellow is also having coronary artery disease is what you have to check for. Do an angiogram, see for the occlusion. Is it the cause you try to identify? Is the golden rule. And another important thing, generally aortic regurgitation leads to what kind of situation? Pulse pressure, how it will be? Wide pulse pressure. High systolic pressure will be 180, 190 like that. Diastolic pressure will be 40 or 50. So, in spite of having aortic regurgitation, can the systolic pressure instead of being 180 can come down to 120 or 130, which is called systolic decapitation. If the aortic regurgitation is associated with aortic stenosis, instead of having a high systolic pressure, there will be a systolic decapitation is the golden rule that you should not forget in the clinical medicine, doctor. And why there is a development of angina? Continuously left ventricle is pumping against a stenotic valve of the aorta. Hence, obviously there is a left ventricular hypertrophy, increased myocardial oxygen demand, which leads to development of angina, which is the second important reason. Reason number 3 is, in the case of the aortic stenosis, there is a high amount of pressures inside the chamber at the time of diastole when the coronaries are filling. So that is the reason coronary filling become impaired. because of the high pressures, diastolic pressures within the chamber in a patient with aortic stenosis, which also leads to development of angina, is another important reason that should not be forgotten. Another important thing is syncope. Why? Because stenosis leads to decreased blood supply to the brain, leading to the development of the syncope. And finally, when the left ventricle continuously pumping against the high pressure happen to fail at a point of time, that leads to development of the congestive heart failure. So these three important gurus you should not basically forget. Now, how will be the typical pressure volume curve in the case of aortic stenosis, doctor? Typically, you are having 4 points, 1, 2, 3, 4, right? So, what is this volume at the level of point 2 called as end diastolic volume? It is at the end of the diastole. Later on, it has undergone isovolumic contraction. So, that is the reason the pressure has increased. Then the aortic valve has opened, and that made the blood to be pushed out, and that's the reason point number 3 to point number 4 is called the stroke volume. So generally in a patient with the normal heart will have a very wide diameter of this loop with a normal cardiac output, but a patient who is having aortic stenosis, because of the decreased cardiac output, the point between 3 and 4 become narrowed down, hence this particular pressure volume curve become narrowed down is what need to be remembered. Finally, you will be reaching a point of volume called end systolic volume is what I want to underscore, and later on once more there will be isovolumic relaxation and the heart become filled with the blood, left ventricle, and that will finally bring it to point 2, which is the end diastolic volume is what I want to finally underscore to all of you. So finally, what is your answer? Aortic stenosis. Good. So let's go to the next question. In a patient who is having severe bradycardia, can you give a calcium channel blocker like diltiazem? Never give it. Diltiazem, verapamil, beta blockers, they all lead to development of a profound sinus bradycardia, should not be forgotten. Probably in your clinical practice you will get a patient who is having 40 or 45 of pulse rate. First thing that you should ask for is what? Are you receiving any beta blocker recently introduced to you? Generally hypertensives with recent introduction of the propranolol can lead to the development of bradycardia. Let's go to the next question. Splenic artery, everything is true except, favorite question, splenic artery is an end artery, does not anastomose after the pencil like arteries come out of it. So typically splenic artery will be terminating in the proper substance of the spleen, where small tufts of the pencil like minute arterioles will be coming, but these arterioles will not be anastomosing with each other is what need to be remembered. Let's go to the next question, fundamental question, doctor. Vagus nerve, does it carry preganglionic or postganglionic fibers? It carries preganglionic fibers. Finally it will end into a ganglion which will be carrying the postganglionic fibers is what need to be remembered. So this is the dorsal motor nucleus of the vagus. Vagus is having a very important nucleus which is located in which part, doctor, of the brainstem? Is it in the midbrain or pons or in the medulla? Medulla. Very good, very good. Which cranial nerve will be ending at the level of the lower pons? 7th. 8th, 9th, 10th, 11th will be there in the medulla. And whereas 5th, 6th, 7th will be there in the level of the pons is what need to be remembered. That's how now we get lateral medullary syndrome of the Wallenberg, we get the lateral pontine syndrome which occurs because of the all this AICA, PICA, occlusion. Anyway, we'll take one of that much more detailed session. So you can take opportunity to attend the anatomy, which is going to be about 60 hours of anatomy for MLE. Whether MLE or Indian or Asian, Chinese or anything, doctor, knowledge is the knowledge, only different ways of asking. Luckily Indian entrances are shifting more towards what you call concept based exams, okay. So please remember, finally they will be carrying all these what you call as preganglionic fibers. What is the difference between a parasympathetic autonomic ganglion versus sympathetic autonomic ganglia, doctor? The parasympathetic autonomic ganglia will be closer to the organ. So that is the reason postganglionic fiber is very short, preganglionic fiber is very long is what need to be remembered. Whereas sympathetic ganglia will be paravertebral. So that is the reason their preganglionic will be shorter and postganglionic will be longer is the golden rule which you should not basically forget. So all of you know what is Auerbach's plexus, which is myenteric, and Meissner's plexus, which is called submucosal. Let's go to the next question. What is the difference between the right recurrent and left recurrent laryngeal nerve is what the exam asked you, which will be passing through the superior aperture of the thorax. Please remember, doctor, this is the anatomy dissection where you have caught this right recurrent laryngeal nerve. I like to ask you a question. Whenever you have any Pancoast tumor, is it the right or the left recurrent laryngeal nerve? Which is the one which is more vulnerable to become compressed? Left recurrent laryngeal nerve. That's the reason elderly person who has smoked throughout the life has come with the complaint of the hoarseness of the voice. You should think of the possibility of any bronchogenic carcinoma. In the superior mediastinum, the vagus nerve will be giving off the recurrent laryngeal nerves, and there is a difference between the two. The right recurrent laryngeal nerve will be recurring and passing under the right subclavian artery and goes back towards the larynx, which it will be supplying. Whereas the left recurrent laryngeal nerve's vascular counterpart is not subclavian, it is the arch of the aorta. So it will be passing in relation to that. That's the reason any aortic aneurysm compresses the left recurrent laryngeal nerve. So right recurrent laryngeal nerve related to right subclavian artery, left recurrent laryngeal nerve related to the arch of the aorta is a golden rule that should not be forgotten. And one more thing is, right and left, if you compare, left recurrent laryngeal nerve is more in the lower thorax compared to that of the right recurrent laryngeal nerve. That's the reason it is much more vulnerable to become affected by the tumors of the mediastinum, is what I want to underscore to all of you. Now let's go to the next question. Vertebral artery will be passing through everything except, it won't pass through intervertebral foramen. It will be passing to the foramen transversarium, is what we need to fundamentally remember. So this is how the vertebrae will be having the transverse foramen transversarium through which the vertebral artery will be passing. The vertebral artery from the two sides will be forming what, doctor? The basilar artery. Finally, basilar artery will be dividing into posterior cerebral artery. Posterior cerebral artery will be communicating with the posterior, with the help of the posterior communicating artery with the internal carotid. And internal carotid will be giving rise to the middle cerebral artery and anterior cerebral artery, which are both combined by the anterior communicating artery, which is the most common site for the berry aneurysm. That's good, that's good. Let's go to the next question. Now you got the kick. Axillary lymph nodes, typically it is the apical part, which is the one place where it will be terminating, is what need to be remembered. So you have a pectoralis major group, axillary lymph nodes of different levels, and you are having finally supraclavicular lymph node, and the internal mammary group is what I want to underscore to all of you. So lastly, there are about 4 questions of, don't torture with the statistics, but statistic questions are there. I will make you very palatable for that. So I still respect that feedback about statistics from you. So the distribution of random blood glucose measurements in 50 first year medical students is found to be a mean value of 3. And the standard deviation is considered to be 3. Based on this, can we conclude whether it is a symmetric curve of distribution? Is it a right skewed curve, left skewed curve? What exactly it is, or easiest way is nothing can be concluded. So now the question is, what is meant by this skewness? If the distribution is asymmetric instead of being that symmetric dumbbell shaped curve all of us read in the last pages of the Park textbook, no? If it is not like that, it is called skewed. Positively skewed means what? There are a lot of scores that are there in the population. If the scores try to cluster more towards the lower end of the scale, then that means there are more number of people who are having small scores. Then it is considered to be increasingly fewer scores at the upper end, then it is considered to be positively skewed. The best example is the paper is very tough, then more number of people will get lower number of marks. So it is more positively skewed, candidates are more negative, right, negatively spirited at the end of writing test. So this is an example of, this is an example of a symmetrical distribution of normal distribution curve. Now why is it so symmetrical and bell shaped, doctor? Because the mean, the median and the mode of this normal distribution is equal. That is called as a normal distribution, is what need to be remembered. So if you take a standard normal curve, the mean value will be equal to 0 and the standard deviation generally will be 1. So in this given case, the standard deviation is 3, that's the reason it is less likely to be a symmetric distribution, is what I want to underscore to all of you. And what is the importance of the standard deviation? If the standard deviation, most of the times 68% of the observations will be fall within 1 standard deviation, 95% within 2 standard deviations, and 99% in 3 standard deviations is what need to be 99% in the case of 3 standard deviations from the mean is what need to be remembered. Now this is an example of a positively skewed distribution. That means more number of people are having less value and less number of people are having more value, is what need to be remembered. So let us look at the frequency of having the sex partners. Majority of the people have reported that they have either 0, 1 or 2 sexual partners in a given year. So there is a reason the people who have 15 partners, who are the great people who have CD4 count also only 15, is falling very less. So this is an example of a positively skewed distribution. Whereas a negatively skewed distribution is, if you take the people who are retired after the age of 65, obviously the number of people who are retired after the age of 65 will be more, no? So that is the reason it is the people with this particular high value of age among the retired people are more. So that is the reason it is negatively skewed is what need to be finally remembered. So in this given case, basically the examiner has given you the mean value is 3, standard deviation is 3. Nothing of this is speaking about whether it is right or left skewed deviation. If you are given all the values, you will put all the values and see more number of people are having less values or more values, and then decide whether it is right skewed or left skewed. Hence the answer is nothing can be said conclusively is what need to be finally answered.